But just to introduce this panel, which is really, I think, a landmark piece of work done by colleagues here. And it's on patients and citizens and the public's recommendations for a better primary care system. So I'll just do some brief introductions. Dr. Tara Kiran is a very close colleague who's the Fidani Chair of Improvement and Innovation at U of T and the Vice Chair for Quality and Innovation. She also practices clinically at St. Mike's Family Health Team as well. She's the lead for OurCare, a national initiative that she's going to be talking about to engage the public in co-creating the blueprint for a stronger, more equitable primary care system. She's joined by Neb, who's a family physician at St. Mary's Hospital, Academic Family Medicine Group, and also the Quality Improvement Program Director at the Department of Family Medicine at McGill. He's the Clinical Director of Health Quality Academy and a member of the Quality Improvement Advisory Table of Quebec's Ministry of Health and Social Services, and he's played a really big role with OurCare as well. And they're joined by Sandra, who's here as a patient partner as part of the OurCare project. She's a project analyst quality assurance specialist at Shared Health, Shared Services in Manitoba, and has a role and responsibility around testing software deployment in a variety of settings. And she's bringing her perspective as a patient and someone who's brought that perspective to OurCare. So I'll turn it over to you, Tara.
Thanks so much, Andrew. Hope everyone can hear me okay. So I'm here today as Tara Kiran, but I will say that what I really hope to do today is to kind of be an amplifier or maybe an old school boombox for all the people that couldn't be here. The hundreds of people that we've engaged across the country, patients and members of the public, people living in Canada, about what it is that they want to see done differently when it comes to primary care. Now, all too often when we have these conversations about primary care reform, the people in the room are often, researchers, family doctors, other health professional organizations, people in government. And we see that today, actually, we far outnumber the patient and public voices. But ultimately, the system actually should be designed with the patients and the public needs, perspectives, and priorities front and center. And that's why I'm excited to share with you kind of what we've heard from the public, because I hope in this process over the next day and a half that that's what we keep front and center. And I'm going to end today with actually, a summary of where it is that we've landed. And I hope that's going to be a great takeoff point as we have our discussions. So to get the patient and public perspective, we launched this national initiative called OurCare. It has 3 phases. The first was launched in the fall of 2022, where we did a national survey. We heard from more than 9,000 people across Canada. And we've put our results up publicly. You can just go to ourcare.ca/national survey. You can actually access an interactive data tool where you get to see all of the results and play with them, see how they varied by region, by sociodemographics. I'm actually not going to present most of those results today, so you can take a look at them on your own. But what I do want to talk to you about are the things that we heard in phases 2 and 3, because that's when we had actual dialogue with people. Phase 2 were a series of priority panels. So we gathered 30 to 35 randomly selected people in each of 5 provinces. In each province, they spent 30 to 40 hours learning about primary care delivery and coming up with recommendations. And then we did 10 community roundtables. So that's where we really focused the voice on marginalized communities. And I'm going to tell you more about each of these phases and what it is that we learned. As I start, I do want to make sure that I thank, the people behind this that allowed us to do this work: Health Canada, Max Bell Foundation, and Staples Canada, even the odds ratio, and a huge set of stakeholders and collaborators that made this possible. One of the things that I've loved about OurCare is learning about primary care in other provinces, because it's taught me how much I don't know and how we really do have 13 different primary care systems in Canada. So huge thanks to our OurCare leads, who you can see on the left, family medicine and primary care leaders from different provinces as well. My partner in this work has been Peter McLeod and the Mass LVP team. So Peter runs Mass LVP. It's an organization that's founded on this principle that ordinary people can solve complex problems if you give them the education and the facilitation. And that's what his organization does. And they do it really expertly, and it's the reason why we've been able to do this work. I will say we've had engaged tons of partners across the country, and it does give me hope that they've been engaged in this process and have actually listened and engaged with the results themselves. So I'm hopeful that something more is going to come out of this. So to start, I want to tell you a little bit about the OurCare priority panels. This is a photo here of our Ontario priority panel. It kind of launched the whole thing off actually just a year ago this past weekend. So a year ago this past weekend, these 35 strangers who you see on the photo gathered for the first time virtually. And then they spent 3 Saturdays virtually with each other, learning about primary care. Before then, we brought them in person, actually just across the street to the Doubletree Hilton, and then a couple blocks from here at the Lee Kesching Institute, where we had them gathered for 4 days in person. And so just to emphasize here, you can see from the photo, these are people who come from very different backgrounds, different ages, different life circumstances, different genders, different ethnicities, racial backgrounds. And despite their different experiences and perspectives, what you'll see is that there was so much that they agreed on. So where did these people come from? So we actually randomly selected 35 people from Ontario out of a pool of 1,250 people who volunteered for this. So we did this national survey. We said, okay, you finished the survey. Would you like to be further involved in primary care discussions? And in Ontario alone, 1,250 people kind of raised their hand and said, yeah, I want to spend 40 hours talking about primary care, which is pretty incredible. So it just shows you how engaged many people are. And then we randomly selected from this 1,250 people, a pool of 35 who roughly represent the demographics of Ontario. And you can kind of see how we did that on the slide in terms of the different makeup, gender, age, ethnicity, income, whether or not they've had a primary care, a doctor or nurse practitioner. And you can see here that they came from all across Ontario. And then we've since repeated this process. So we did it in Ontario, but then and Ontario's ended in February, and then in May we were in Quebec, and we actually just released that report just earlier this month, and had a wonderful article in La Presse recently just describing that process. And then in June we were in BC, in July in Nova Scotia, and just this past October, just after Thanksgiving, we were in Manitoba. And I just want to say that the Manitoba panel was a little bit different from the others. Actually in Manitoba, so as I mentioned, we had these advisory groups that shaped each of the OurCare panels. And our advisory group in Manitoba said, one of the biggest problems we facing Manitoba in primary care is the inequity in access for Indigenous populations. And we wanted to really take that seriously and address it. And so we aimed actually to have 50% of our panel be Indigenous. We were able to get in the end close to a third. So it had a very different feel, I think, to the panel because of that deliberate overrepresentation of First Nation, Métis, and Inuit in Manitoba populations who we know are underserved by primary care. So what did these people do together for these 30 to 40 hours? Well, we were very lucky to have many speakers, experts in primary care, tell them about the system. So we had many people who you see in the room today, Danielle Martin, Andrew Pinto, others. They spoke to Camilla Premji, they spoke to Jane Philpott, I should say. So lots of wonderful people who provided expertise and told them about everything from how primary care 101 to kind of why is it that they can't have access to their own data, and how does it work with teams. So lots of different topics that were covered, and lots of questions and answers that were dialogue that was had with members of the public. But I will say that, the speakers is just one part of the 30 to 40 hour curriculum. So a big part, and I think an even more important part, is this part really talk to each other, because they're bringing together these really different perspectives. And we give them this really hard task that they have to come to consensus at the end of these 30 to 40 hours. And so a lot of the time is spent in deliberation, in dialogue, to try and identify core values, issues that they want to solve, and then of course land on some recommendations. I wanted to throw this slide up because I will say my colleagues here at Mass LBP always warned the panelists that, and we call them panelists, our public volunteers, they always warn them that somewhere in this process, you're going to hit the diamond of despair. And I have to say, I think, I felt it this morning as we were having this discussion, when you hear about all the problems, the complexity of the problems, how long the problems have been gone on for, and how they might be so difficult to solve, and you're going to feel like you can't move forward. But they warn them that, you're going to feel like that, but you are going to be able to push through respectful dialogue and listening and hard work. You'll be able to land on things that you agree on that will help us to move the system forward. And so I say this to you because we may be entering this diamond of despair, and we need to do the same, figure out how to move forward. So, every time we've done this, despite people's diversity, we've learned how much it is that people agree on. So in every province, they've come to agree on so much. And then when we look across the provinces, there are common themes that really emerge. And here what you can see are the common values that people put forward. The number one at the top is accessibility. People want access to primary care, period. They want access for everybody, and access has multiple dimensions. So it also means like making sure that you have access no matter where you live, no matter, if you have a physical disability, no matter, if you struggle with income, if you're Indigenous. So access for everyone, and that was their fundamental kind of value, and it was tied in very closely with equity. Another core piece that came out over and over was this idea that we need to focus on prevention, wellness, holistic care, and stop having a system that's just focused on sickness. People want to be well. We need more accountability and transparency, considerate, respectful, empathic care. They talk about the need for patient-centeredness, so that things should be designed with the patients at the center and their needs thought about. Sustainability, they want a system that continues and is there for them in the future, and universal, which really laying strength to this idea that it needs to be there for everybody. So in addition to the values, there were issues that they put forward, and then these common recommendations. And actually you can read the full reports that are actually written by members of the public on our website at ourcare.ca/priorities panels. And we've got some small videos there too, which I think really allow you to hear the public voice. And I wish that I could bring, the hundreds of people we heard from today. I can't do that, but what I could do is the next best thing. And I wanted to thank Andrew Pinto and Izzy and the organizers for allowing Sandra Epp to come. And Sandy was one of our panelists in Manitoba, so our most recent priority panel. And I'm going to let her introduce herself to you and tell you more about who she is, why she volunteered for this panel, and also speak about her perspective on what it is that stood out to her from the things she learned and the recommendations that rung most true. So I'm going to turn it over to you, Sandy.
Thank you. Okay. See, can you hear me? Do I need to turn? There we go. So I have notes, more because of the fact that I can really talk. And if I don't stick to my notes, this might be a lot longer than we anticipated. My name is Sandra. I am a person who works in shared health. I've worked in the healthcare industry for about 15 years, but that's not what brought me to this panel. The main driver for me was the fact that I have two teenagers, 16 and 18, who started experiencing a variety of physical and mental health issues prior to and throughout COVID. My youngest, my 16-year-old, 16 now, started experiencing gender dysphoria, and I was completely unprepared. We reached out to primary care, and we were referred to another specialist, and we went on a wait list, and then specialist and wait list, and we just continued this path along a very frustrating and tumultuous time to try and get my son care. And the big thing was, I'm sorry, you have to wait. But gender dysphoria is painful, both mentally and physically, and waiting with a mental health condition can be disastrous. Eventually, my son ended up trying to take his life. Sorry, I'm going to get emotional. He tried to take his life because there was no one to hear him and there was no one to help him. And even though we had a care provider who truly wanted to help, He didn't have access to the resources that he needed. So we were left stranded. At the same time as all of that was going on, my 18-year-old started developing a tic disorder in school. And then we went into the remote learning, which is great for them because they didn't have to mask. But when they went back to school, the sensory overload, the tic disorder, it was verbal and physical tics. They were trying to mask, and it was just so much to handle. Again, we went to physician. We were referred to a clinic. There was an 8-month wait list before we got triaged. And then they referred us to a tic disorder clinic, which was another 12 to 18 months. So for almost a year and a half, I had a child who was undergoing these symptoms and no resources to help us. So again, there was despair, there's all of that. And one thing that I'm confident is that because they struggled so hard to manage the disorder on their own, they started becoming chronically fatigued, which then turned into a pain disorder. And now they've been diagnosed with fibromyalgia. So my 18-year-old is disabled and at home, unable to finish school, unable to get out of bed a lot of days. And again, we still don't have resources to help. So those drove me to say, hey, I need to put my voice to this, right? It's easy to sit there and complain about wait lists and complain about physicians and all of that. I need to get involved. So through Shared Health, I heard about a patient engagement program. I got involved in that, which brought me to OurCare. And it's been wonderful. It's been an amazing experience. What was really incredible was the fact that it helped me get out of my position as care providers are my enemy and realize that care providers are almost a victim of their own system. Even when they want to help, they can't because they don't have the continuity themselves. So being on that panel helped me to hear from other care providers or hear care providers speak what they wanted to see change. It helped me to realize that we're not adversaries, that we're a team. And then I got to listen to the stories of other people like me. And it was encouraging to hear how we all were coming together to lend our voices towards wanting to make a change. There was such a diversity in the group, and yet everyone was focused on, wanting to preserve rights for LGBTQ, wanting to take care of people in First Nations and rural and remote communities. And we had that sense of unity, even though we were so different and came from so many different backgrounds. It was also heartbreaking to hear how many of our First Nations communities, Inuit, Métis, the Indigenous population, how many of them had stories that ended in tragedy. And they stories plural. There was one gentleman who shared he had 3 different stories of tragedy that happened to him and his family. And it was all because of the fact that they were rural and remote and they didn't have the service. So what that did was it brought us together as a group, determined to come up with recommendations to make their lives better. And it seemed to me to bolster that a sense of reconciliation within our group. We all wanted to make First Nations, Inuit, Métis, Indigenous care a priority. And so a lot of our recommendations reflected that. I had identified some of my recommendations that stood out to me, but you guys have all talked about them, right? Primary care teams, having a holistic approach, having a child with fibromyalgia, it's not just fatigue, it's not just pain, it's not just tics. They all fed into each other. And a lot of times the primary care providers wanted to deal with just the fatigue, just the pain. And it's not, it's a holistic approach, and it involves mental health as well. So not being able to include all of that into one picture made it impossible for us to take care of her. And she did suffer. The next one was the integrated medical record, so that patients can understand what's in their record, but also that care providers can transfer it. With my son, the number of referrals that he got sent to where he had to tell the pain of his dysphoria over and over and over again. And every time we came home from an appointment and he got told, "I'm sorry, I can't help you," he would cut himself. And it was a very physical reaction to not having that help. So having to re-experience the trauma over and over again might have been mitigated if we'd had a shared list or shared communication ability. Being in tech, I realize how impossible that is. So I recognize that's not an easy fix, but it's an important one. And then the last one is access to care. including virtual care solutions, supporting rural and remote communities, becoming creative in whether you send doctor assistants. Forgive me, I'm not as technical or comfortable in that area, but having different types of people who can provide care, not just having a doctor, extending access to people. Those were key priorities. And then one thing that I added afterwards, or two, was patient education. I didn't know how to help myself. I had the privilege of having internet and access to people in shared health and healthcare industry, and I still didn't know how to help my kids. I still didn't know how to make it from day to day. And I am aware that there are so many people who are in much less privileged situations. I am sure that if my son had been in that kind of family, that he would have taken his own life. Like I'm positive. So knowing that just the privilege of my situation caused me to be in a better outcome, it devastates me. So educating the public to know what services are there, what is already being done is huge. And then the last is just feedback and evaluation, is just letting people have the voice to say, this is where my problems are. These are the things we want to fix, because a lot of times we feel like we're just screaming into the wind and no one can hear us. So I know that's longer. I tried, but the biggest thing, my belief is primary care is foundational. It's the foundation. If you don't have a strong primary care, people are going to go to acute care and they're going to end up getting to the point where they feel like they're hopeless and possibly lose their lives. So we need to spend the money on the foundation. It may not be as pretty as some of the more exciting stuff, but it's what's important. So sorry for taking your time.
Thank you. Thank you very much, Sandra. I think it helps for all of us to hear directly from a patient and a public member to see how you experience this process of OurCare consultations. So I'm going to be presenting you now with the recommendations from our panels. Like Tara said, there was a lot of common elements that emerged when we looked across all 5 panels, and we're trying to go over them together today. I'm sad that I cannot post Melanie Ann's 10 facets that she presented this morning, because when I was listening to it, I could recognize a lot of these recommendations from our panel members that really tackled the same issues. So first of all, our panelists talked about the importance of upstream action. So they recognize that we need to invest more in primary care. They wanted to expand public coverage to include physiotherapy, mental health services, medication, dental and eye care, because they understood that the financial barriers were the most important for the access of these primary care elements. They wanted to strengthen the links between primary care and community organizations. And also, all 5 panels wanted to address the social determinants of health. One of the main frustrations that was voiced over and over again was what Sandra said, the lack of access to electronic medical record. Here's the quote from the BC panel. We recommend establishing a central medical data platform for clinicians and patients that provides province-wide access to electronic medical records, regardless of the database software used in any given location. The goal is to facilitate continuity, portability, comprehensiveness, and efficiency of patient care. The panelist wants records to be connected to each other, exchanging information, and ultimately to have patients being owners of their own data. They also talked about virtual care, especially to enhance equity and access. So this is the quote of the Ontario panel. We recommend prioritizing the expansion of comprehensive virtual care models to those with mobility challenges and those in rural, remote, and northern areas. The long-term goal, however, is to offer publicly owned and accountable virtual care to all. So they wanted virtual care to enhance access in rural and remote locations, and they also wanted to be tied with in-person care. As an important element for virtual care, they want affordable and reliable internet services in remote locations. They also recommend ensuring good public infrastructure for people not having access to internet. Finally, for many equity-deserving communities, it was important to bring care closer to them by mobile care options. There were many recommendations related to diversity and inclusion. They underlined the importance of training healthcare workers in cultural safety and anti-discrimination, including a community perspective in curriculum development. The panelists want a workforce that better represent the population it serves, and they suggest to have barrier-free pathway to primary care professional education, especially for equity-deserving communities. They also want to indigenize the medical curriculum and integrate Indigenous models of care. All 5 panels discussed the present workforce crisis. They wanted a facilitated integration of internationally trained professionals in primary care. They want increased number of family medicine residency spots with a special attention to equity-deserving communities. And they believe the solutions should be found to decrease the administrative burden on healthcare professionals and measures to be taken to keep the workforce in their provinces. It is clear that the panelists want communities and public to be involved in decisions about policies that affect primary care. So this is a quote from Quebec. We recommend that the Quebec government, local governments, health and social services institutions, and political parties commit to involving the public in decisions that affect primary care in order to respect their voice and take their opinions fully into account. Most of the panel members learned a lot about healthcare system when they were doing this, and so they really wanted that for the rest of the community and the rest of the members of the public. So they really wanted to strengthen that and to make sure that the community is involved in primary care policy, delivery, and measurement. They wanted to educate the public on their rights and also on their value of the primary care, and understanding the complexity of the system, they found that it was very important to support patients to navigate the system itself. Finally, they really wanted to be transparent and to be able to measure and report on the primary care systems, including the impact of the reforms that we're putting in place. And some panels also underlined the need to increase research in primary care to support these evaluation efforts. One of the biggest recommendations that everyone agreed on, and we heard a lot about this today, was the value of team-based care. And by team-based, we mean interdisciplinary teams. The quote here is from Nova Scotia. We recommend increasing the number of community-based collaborative care teams so that every person has access to multidisciplinary care and medical professionals can spend more time with patients and less time on administration. Since there is a big variance in how team-based care is already implemented in the provinces, we also saw that in the recommendations. So the places that didn't have a lot of team-based care wanted to start the team-based care in areas with greatest needs, to foster, set up, and fund CHCs, access centers. In provinces that were a little bit more advanced, like in Ontario, Quebec, we see the recommendations regarding amalgamating walk-in clinics into the team-based models, or to give non-physician team members more autonomy and latitude. Finally, the boldest recommendation regarding team-based care came from Ontario and BC, and was suggesting that the primary care should be organized as public school system. So this is the quote from Ontario. To ensure that every Ontarian has a primary care home, the government should move towards automatic rostering similar to the public school system. While health teams should be mandated to accept any patient from their catchment area, it is important to maintain an element of patient choice. I think we will talk about this model in different other countries where it was made possible. Thank you.
So in addition to doing these priority panels, we also thought it was really important to give voice to the people who often don't have a voice, the most marginalized in our communities. And so that's what the community roundtables were really designed to do. This is a picture actually of our second community roundtable. This occurred in Ontario, in the East GTA and Durham region. We did this one in conjunction with the Black Physicians Association of Ontario, Taibu, and Durham Community Health Centers, and it was really focused on the African, Caribbean, and Black communities living in that region. And importantly, like this community roundtable actually, really I think reflected intersectional perspectives, because many of the members faced many barriers. So they were not just Black, but they were new immigrants, often from many from the African continent, actually representing a number of different countries here. And they actually were Francophone, many of them. And so there were multiple different barriers and that affected their experience, and also the needs and priorities that they put forward. So you can see here like a summary of the 10 kind of roundtables that we've done across Canada. And these have been a big lift. And I want to just, kudos to our Mass LBP team who've managed to carry them out in conjunction with, you can see here, a number of different community partners. And I say, what's been really impressive about them is the team has worked really hard to break down barriers to ensure participation. So several of these roundtables have been simultaneously conducted in 4 or 5 languages in order to really ensure participation. The one in Quebec that I managed to actually pop into, that I went, in Parc Extension, a newcomer community with many people living with lower income. There were 24 participants, and I think representing 22 different countries. So that was just actually blew me away. So it just represents, I think, the diversity of people in Canada, and I think the very different needs and perspectives that people bring forward. Well, I say different needs and perspective because actually what was really interesting too, though, is that even in these roundtables, some of the same themes we saw coming out. And so that same roundtable in Parc Extension, they talked about how they often actually came from countries where they didn't have access to primary care or healthcare. And so they were actually grateful that we did have a system, but then, they didn't necessarily have access always to that system. And it was confusing to navigate, and it was hard to figure out, there's some things that they would have to pay, for example, out of pocket for, or they would need to go to the emergency department because they don't have a family doctor. And so interestingly, we see, though, some of these same recommendations that we've just talked about, expanding team-based care. Many people talked about how community health centers or Indigenous primary health care models have actually been very successful in being able to provide them with the care that they need. They talked also about ensuring access to their own records, expanding coverage, having a holistic approach to care, empowering patients to have a more active role. They really talked a lot about trying to support foreign trained health professionals to work in Canada, because many of them knew foreign trained health professionals who weren't able to work in Canada. And it relates actually to this idea, though, that they also brought out, which is this idea of increasing the representation within our healthcare workforce, and accelerating the integration of foreign trained professionals is one way we can do that. Of course, there are other ways as well. And although many of these themes were also voiced in our priority panel, I think they were given more emphasis in our roundtables, where it was very clear that many of the people we talked to there, who are often not consulted, and they were very grateful actually to be consulted in these processes, how much they experienced racism and discrimination. I think one anecdote that stuck with me is in Manitoba, we had a roundtable with Indigenous youth. And the youth often, I think, don't have a family doctor, don't have primary care access, so they end up having to need to use the emergency department. But they don't want to go to the emergency department because, what they said was, we go into the emergency department expecting to be discriminated against. So really a heartbreaking thing to have sit with you. So that's, a real call that we heard in multiple different dimensions, to address discrimination and racism. Of course, providing language concordant care, really important, respecting Indigenous self-determination. And then this idea that, there are different sometimes funding pathways for different people. So whether you're an IFH or if you're an asylum seeker that's undocumented, or you're living on in a reserve, those are all different funding models that sometimes then pose a barrier to your care. So lots that people agreed on, and I hope that you guys will take that into consideration as we think about the working groups this afternoon. I do want to spend just a few minutes talking about how what people told us aligns with where we are. I mean, I mentioned this morning that, this is the one slide from our survey that I did want to present, which really shows that, more than 1 in 5 people in Canada don't have access to primary care, but it also shows the stark variation by province, where we have, in BC, it's more than 1 in 4, and in Quebec and Atlantic regions, close to 1 in 3, which is pretty incredible. And what's interesting is that even in the survey, when we adjusted for a whole bunch of factors, what you see as being the strongest factors really relating to whether you have a family doctor or age, with people who are older, more likely to have a family doctor, but then the region that you live in. So the region you live in continues to be one of the biggest determinants about whether or not you have access to primary care in Canada. And we can go further to kind of look at this perspective related to teams. So one of the number one kind of priorities that we see, us coalescing on this morning and this afternoon, we can see that, when we ask people who else works in their practice, if they do have a family doctor, we can see, like about a third maybe say they have a nurse, just under a third say a nurse practitioner, but very few people say other health professionals beyond that. And again, if we look by province, we can see a huge variation. So this is just looking at proportion who report having a social worker, and you can see much more likely in Ontario and Quebec to report having a social worker as part of their family practice care. And again, when we look at adjusting by a whole bunch of factors, the one factor that stands out determines whether or not you have access to an interprofessional team is which province you live in. And so interestingly, it's actually very hard to get the data about, how many people are attached to a team in Canada. And I'd love to talk more about that this afternoon. And we've actually prepared some kind of handouts to try and delve into that, because we've actually tried to find the data and it's been nearly impossible. So of course, teams means spending more money. And I will just say that, some of the data we've looked at has shown us, and this is data from the World Health Organization, Canada does spend less on primary care as a proportion of the total health budget compared to other countries. And this is a comparison with other OECD countries. So yes, teams will cost money, but we need to spend more, and many of our peer countries are spending more, or let's say the majority. Rick also mentioned that we have a paper coming out next week that's comparing Canada to a number of other countries that have higher primary care attachment rates. And what we can see there is not only are they spending more in primary care, but they're actually a greater proportion of their total health spending is public versus private. And that's, I think, another really interesting thing for us to reflect on, because it aligns also with those recommendations that many of our patients made around expanding what is covered under Medicare. So you heard a lot from us today, and what I want to leave you with, though, is we've been working towards a final report that we hope to release in February. And in this final report, we're going to release sort of some of the recommendations we talked about, but we really want to tie it together with this vision for what is it that people, patients in the public, should expect from primary care based on all of the consultations that we have. And so I wanted to just share that, those are thoughts with this idea of an OurCare standard based on all the work we've done. It's in draft form, what you'll see, so we definitely appreciate feedback, and we're going to be getting lots of feedback from our stakeholders as well as the participants who've been in the priority panels and roundtables with us. But here are the 5 things that right now we think have come out of our consultations. First, that everyone belongs to a publicly funded primary care team connected to community and social services. So there's a lot of things to unpack there, but publicly funded. So yes, it should be free at the point of care and covered. Primary care. So by primary care, I think we're talking about the 4 C's. That means care that's continuous, that's first contact, it's comprehensive, and that coordinates things across the health system. So we're not talking about one-off episodic access. And connect team, so we can talk and define team, but I think in general, we're talking about family doctors working with other family doctors and nurse practitioners, so most responsible clinicians working together with other health professionals who can then extend their capacity. And then of course, connecting to community and social services, addressing that full holistic range of care. The second, we've heard a lot about today too, is that one big issue is people can't access the care when they need it. So the second standard is everyone can access their primary care team in a timely way. And probably related to that is in the mode that is appropriate or that meets their needs. So if that's for some people living in remote and rural communities, that may involve virtual care as an example. Third is everyone can access their medical record online and share it with their clinicians. Should be simple, but it's not. And then 4, everyone is served by a primary care system that is accountable to its community. And so again, we can unpack that a bit. So what does it mean? I think it talks also about community governance, which is a really clear recommendation we heard about, but it also means like reporting back on like, where are we at with primary care in the system? Like, how about the money we're investing? Are we getting a return on investment? And then 5th is that everyone receives culturally safe care that meets their needs from clinicians that represent the diversity of the communities they serve. So this means care that's anti-racist, that's not discriminatory, that's in the language that people can speak and interact with, and meets their needs means that, if you need trans care, if you need addictions care, that care is there in primary care. It's not that the provider or the practice decided it's out of scope. I mean, everything for primary care should be in scope in these primary care teams. So that's the draft OurCare standard. I hope you think about it as you are in your working groups this afternoon. Would love to get feedback from you early on, and if we're missing things, if the words need to be adjusted. But I just wanted to leave you with this last quote as we end off, and maybe we might have a bit of time for questions. And this last quote is from our Manitoba Priority Panel, and it really, to me, drives home the need for us to keep that patient voice front and center. Together, we feel that the current primary healthcare system honors the system more than it honors and cares for the people it should serve. We truly hope this report is the vehicle through which our voices and ideas for improvement are heard and meaningfully acted upon by decision makers. This panel has modeled the respect, compassion, active listening, and relationship building that needs to be reflected in the primary care system. Thank you.
We have time for questions. Can we go back to the OurCare standard?
Yeah.
Just because I noticed some people were trying to take pictures of it and stuff, and
it's still in draft form.
So
yeah.
I think we have time for questions, and we have about 15 minutes. And yeah, we'll start with Ivy back here, and maybe we'll bring a mic over to you. And again, if people could just introduce themselves so everyone knows who's in the room.
Hi, thank you. So I'm Ivy Bergeau, professor at the University of Ottawa, co-lead of Team Primary Care, which we have a number of investigators here. Thank you very much for this. I've been digesting the conversations. I think this is great, this 5-point plan. I think what Rick highlighted, in terms of our aspirations, what we could do. I think what was presented, at the beginning, what I would encourage us to do, this is more of a comment than a question, my apologies, but a crosswalk of aspirational where we want to go, an agreement across a variety of different providers from, what we know in the literature, what we agree on here, what the Canadian public has said through your study. But the challenge will be, how do we get from where we are now to there? What are the pathways to the aspirations, to the vision? What are the strategies? And I really love the analogy, and it's something that we think about in the work that we've been doing in Toronto is about, people should have access to primary care the same way that they have access to school. So that's a carve out for primary care, quite separate from what we think of as the healthcare system. How possible is that? There isn't a federal education act. Each province has an education act, and we all have access to schools. Is that possible? Is that a pathway? That's just one example. I just want to kind of inspire us as we go into our conversations this afternoon and tomorrow about what are potential pathways for us to get there. And I draw lots of inspiration from other countries, but this is the context that we're in, and we're going to have to work with the stakeholders that we have and the challenges and the opportunities within our own system. And I'm really hoping that we get a chance to do that today.
Yeah, I agree. And I would just say that my hope is actually that this is a vision that everybody can agree on, that it's not just a patient and public produced vision, but it's an endorsed vision also among all of our stakeholders. Because anyway, we'll see if that's the case. And I agree with you. We have an implementation problem. Someone said that earlier this morning. And one of the things that we need to think about too is where we are in respect to each one of these 5 things in each of the 13 jurisdictions in Canada. And what we've tried to do actually to support the working tables is we prepared a couple of handouts that have some data that actually compare, like, how much does this province spend on primary care versus that province per capita? Where are we at with teams, to the degree that we were able to get that information from key informants, because it's actually not really publicly available. So let's see where we're at. We're at different places in different provinces. Agree, we need to come up with an implementation plan. And because I was looking for a plant for this slide, I'll just say this is like a summary of some of the things that we've learned from other countries when we've looked, and some of the lessons. But there are some actionable things here. But to me, it starts with setting the goal of 100% attachment and spending more money.
Hi, I'm Dan Ortanyalras. I'm a family doc in Toronto and lucky colleague of Tara's. So this may have been out of scope from the panel, but I'm very curious to hear if this was also talked about. We've heard about it asked or alluded to in a few ways this morning. I think Jane talked about this as a political problem, and then Rick talked about the funding issue. Tara, you just showed the OECD slide. It's not a surprise to me that we underfund primary care when only 70% of all healthcare is publicly funded, and much of what we need for primary care is outside the Canada Health Act. I think when many of us are talking to policymakers, what we often hear is like, but how are we going to pay for this? So I think one of the tough questions also is, how are we going to pay for it? I think the other thing that's also true is when you look at tax revenue in Canada compared to many of the countries that were on your slide, we bring in far less tax revenue, whether it's on a per capita basis or as a percentage of GDP. You can't take blood from a stone. You get what you pay for. If we don't pay for primary healthcare this way, then people will pay for it out of pocket or through their health, through just lack of access to care. So I'm wondering, was there any conversation around, amongst the panelists or on the committee panels about how do we pay for this? And are we willing to pay more out of our pocket? Or, that's a whole nother panel itself, right? Like progressive tax reform, corporate taxes, all of that stuff. But if we want to do the things that we're talking about today to meet the aspirations for, a primary care health system that we all want, we also have to think about the back end and answer those questions for policymakers too.
Yeah, you're right that would be like a whole other panel. So it was out of scope, but I would just say that there are some things that are implied in the recommendations that they made. So people were clear that when we are thinking about spending money, we need to spend more of the healthcare budget upstream. Like, that was pretty clear. In Manitoba, they had this really interesting analogy too, where like hospitals have like foundations to like raise money for them for like new and shiny things. Like, who's raising money for primary care infrastructure and primary care things, right? Like, so people want us to spend, but they recognize that the money is not being spent in the right places. They wanted expansion of coverage. That was like, or removal of barriers. So like either that or removal of barriers. So again, like implying it. I will say that they also had a thought-provoking kind of panel that included Andre Picard in BC, and he really encouraged them to think about public empowerment and way to getting politicians to change as the way to help change the healthcare system. And so you'll see some of that reflected within their recommendations in BC in particular, but all of the panels talked about this idea of public empowerment and building kind of this movement of people who understand primary care and can advocate for it. And then, because I love having slides and backup, so this is a slide and backup just to say that, again, like I think, and this is from our survey, it's like people want publicly covered care. They don't actually, they distrust corporations and, for-profit delivery of things like virtual services. They don't want that. And so somehow we have to be able to stand true to that values. And then we do have to have that more direct conversation about how to pay for it.
Thank you. That was really helpful. Really appreciate the hard work that you're doing and that your patients contributed for the survey. A question and a comment. Will Atlantic Canada be broken down by province in the results? Because while it's perceived we're the same, we're kind of not. I mean, you know, prairie provinces probably say the same thing, right? So yeah, so that would be really helpful if the N was large enough. And then the comment is about spending more money. I'm not 100% sure we need to spend more money. We need to reorient the money that we are spending. Because as we've heard today, there's never a problem putting more money into the hospitals, whether it's through foundations or through the provincial budgets, et cetera. But there always is a challenge to prove that what you're doing is making a difference. Primary care is held to a different standard, in my experience, from a policy perspective. We have to show that we're making a difference right away. And we're not a reactive system, and that's the blessing of having a primary care system, or primary healthcare system preferably. So I think that's a challenge, that when we think about a crosswalk, how do we actually encourage our politicians to understand it's an investment now for the future? And there's been some ROI work, but it's really, really challenging to get it into the hands for decision makers who are based on, 2 or 3 years in the next election. Thank you.
Just quickly to say that contact me if you want the Nova Scotia data. I think we did break it down for that panel and advisory committee. And I think when we did our look across countries, Canada was like in the middle of the pack when it came to the total health spending, including private and public, but it was different in terms of how that total was broken down, what portion is public and what portion is primary care. I've realized also I'm hogging the questions, so I don't know if you have anything else you'd like to say.
Over here. And if people just find interested.
Yeah, so Mike Green, you'll get to meet me in a few minutes on the next panel. I want to follow up on the thing about both the hospitals and how do we make change? That slide about funding is critical. Like, governments still view primary care as just a cost center, and it's all about how much more will it cost. It's not about the value in the investment. I was just at I'm now the president of the College of Family Physicians of Canada. I was just at WONCA, which is the Global Family Medicine meeting in Sydney. The opening video was from their federal health minister, who had received these messages about the value of primary care. And he did like a spiel about how great primary care was for the health of Australians and for their economy, and then announced a $5 billion investment additional in primary care. So if we only talk about health and healthcare, although it's what matters to us as providers, and we don't talk about economics, and job creation and the effect on the economy and things like that, I think that's a part of why we lag. We also don't have the lobbying infrastructure that the hospital industry has. So, each of our provinces has a hospital association. Those hospital associations are funded by hospitals. Where do the hospitals get the money to lobby government? From the government, out of their own budgets. So we don't have that kind of infrastructure for working with government and making change happen. I think that's where we've fallen down. So I would be really interested to hear from the others around the room how we turn that conversation, around.
Hi, thanks. My name is Amin Mawani. I'm with the Schulich School of Business, teaching health economics. I just noticed in your presentation, we've gone a little further beyond this morning, where we were looking at just GPs into vision and physio and all of that. So we may just want to be careful. For example, the analogy we've been using about schooling, all of us have a public school to go to in our catchment, but we may not necessarily have a high school in our catchment. For that, our child may have to travel a little further. So that might be the same for vision and physio and other things. So by putting it all together, we might just lose that analogy. That's one. Hospitals are using a fair bit of their lobbying money from their foundations. The foundations are actually earmarked to say we will lobby for that. And just in continuation of my comment this morning, if we have so many Canadians lacking a GP, we may undo, for example, the entire beneficial aspect of immigration. So just a thought.
Yeah, I guess so just to be careful about the teams. And that's why, to be honest, I'm not sure if the number one here on the standard should be broken up into two different components or not. But like, I do think that right now, like everyone probably needs a primary care clinician, and that clinician needs to be like part of a broader team. And we need to be clear about what the objective is for the team. And I would say that the number one objective, based on kind of what it is that matters most to people, is that we provide everybody with access to primary care. So that means that that we're extending the ability of what in Canada is generally family doctors and nurse practitioners who act as most responsible clinicians to be able to serve more people. So that's probably the number one objective we need to keep in mind when designing teams. I think a secondary objective would be to kind of meet those broader health needs, but that designing the teams to meet the broader health needs as a primary objective may actually not allow us to do the first thing. So the first thing is that everybody really needs to have that access. And one of the things that I've thought a lot about too is that right now we have a very have and have not kind of system, or non-system. So we've got people who have access to a family doctor, some people who have access to an amazing team that wraps around care. You know, I think about actually our patients at the family health team I work in, they have fantastic resources available to them. And then we have some people who just have nothing, like not even like bad primary care. They just like have nothing. And so do we need to like rebalance and retip the scale? So like, okay, maybe not maybe some people have to do with like less awesome team-based care so that some people can have something. And hopefully over the long term, we can invest and build so that everybody can have the best. But right now, it's so unequal. We really need to address that. And I will just also say that, like, you know, Walmart episodic clinics, or, you know, pharmacists doing like episodic prescribing for minor ailments, like that's not actually meeting the primary care need by any stretch.
Any final points from the other members? Okay, I'll just ask everyone to join me thanking you folks for fantastic. Thank you so much, and just like such powerful work. And also, I think it also kind of a radical act to, you know, go out and absolutely survey tons and thousands of Canadians and bring it all together. So thank you.